Welcome back to the Deep Dive, where our mission is to deliver the most essential knowledge from complex sources directly to you. Today, we are taking a sledgehammer to the very foundation of psychopharmacology. We're looking at the molecular hardware that all psychotropic drugs actually target. Our entire guide for this is Chapter 2 of Stahl's Essential Psychopharmacology.
And it's a fantastic guide because it reveals this, well, this really surprising central fact. You've got, what, over 100 essential psychotropic drugs out there
Yeah,
for everything from anxiety to
a
psychosis.
huge number, yeah.
And yet they all interact with just a tiny handful of molecular sites.
Yeah.
It's an incredible simplification.
I find that astounding. It's like finding out the entire universe of psychopharmacy is built with just 3 kinds of Lego bricks.
That's a perfect analogy.
Yeah.
You can really group the vast majority of them into 3 main targets. About a third of them hit what we call neurotransmitter transporters. Another third go after G protein-linked receptors, and then maybe 10% or so target enzymes. If you understand those 3 sites, you're most of the way to mastering the entire field.
And the source material highlights this really interesting push, this modern movement, to rename drugs based on what they do at that level,
Yes.
not just what they treat. So moving away from a name like antidepressant towards something more specific, like serotonin transport inhibitor.
That shift in naming is so important for reducing confusion in the clinic. Think about it. If a drug is called an antidepressant, but a doctor prescribes it for, say, neuropathic pain or OCD,
The patient is going to be confused.
right, it creates these unnecessary barriers. So by using what they call a neuroscience-based nomenclature, we're linking the drug directly to its mechanism, and that's exactly what we're going to break down today.
Perfect. Let's start with that first big target then, neurotransmitter transporters. You hear them described as the great recycling system of the neuron. Why is that recycling so critical for brain communication?
Well, transporters are they're mandatory for what's called selective permeability. A neuron fires, it releases a burst of neurotransmitters into the synapse, but that signal has to be cleaned up fast, really fast.
So the next signal can be sent cleanly.
Exactly. If that chemical isn't recaptured, that's the process we call reuptake or repackaged for later. The whole system just grinds to a halt. It gets noisy. The transporter handles that critical cleanup job.
And when we look at the structure of these reuptake transporters, what does the chapter say is their defining physical feature?
They're magnificent, complex machines. Structurally, they're these large proteins, and they have this signature feature of 12 distinct regions that sort of snake back and forth across the cell membrane. That 12-transmembrane region structure is the hallmark of the ones that matter most in psychopharmacology.
Okay, so help us classify them. Which family do most of our drug targets belong to?
Almost all of the clinically relevant drugs that block reuptake, they target a family called the SLC6 gene family. This one relies on sodium and chloride ions to work. And this is where we find the famous 3 monoamine transporters: SERT for serotonin, NET for norepinephrine, and DET for dopamine.
Let's talk about the energy here, because the diagram in the source, figure 22A, makes it really clear this isn't passive. It's not just floating back in. How does the neuron actually power this?
It's a really ingenious sort of indirect system. The cell has an enzyme called the sodium-potassium ATPase. People often call it the sodium pump.
Right.
And its only job is to constantly force sodium ions out of the neuron. This creates this huge downhill concentration gradient.
So sodium is just desperate to rush back in.
Desperate to rush back in. And the monoamine, whether it's serotonin or dopamine, it just gets a free ride. It hitches a ride, basically. Its transport back into the cell is coupled with that influx of sodium and chloride.
It's the ultimate molecular hitchhiking, and that explains this concept of false substrates, which is where things get really fascinating.
Yes. Because the transporter is built to recognize a specific shape, you can fool it. The source material notes that these transporters have an affinity for molecules that aren't their native neurotransmitters. For example, amphetamine and cocaine can both hitch a ride on the day and NET transporters. That's where their powerful effects come from. MDMA, or ecstasy, does something similar with the SERT transporter.
So if that's how the normal system works, how do most ADHD medications or the SSRI and SNRI class of, quote, antidepressants use this therapeutically?
They block the hitchhiker's door. That's the mechanism. By inhibiting the transporter, the drug literally prevents the natural neurotransmitter from being sucked back into that presynaptic neuron. The book describes it as the neurotransmitter normally only getting a brief dance on its receptor before being recycled,
Right.
blocking reuptake. Well, it significantly prolongs that dance.
Yeah.
It intensely enhances the synaptic activity.
And that enhancement, as you mentioned before, is exactly why calling these drugs just antidepressants is such a disservice.
Absolutely. The clinical breadth is enormous. Because they enhance monoamine transmission, these inhibitors are used across a huge spectrum of disorders. We're talking anxiety disorders like panic and PTSD, OCD, bulimia, even chronic neuropathic pain states like fibromyalgia.
So the mechanism is broad, not specific to one condition.
Exactly, which is why they're estimated to be one of the most frequently prescribed classes of psychotropic drugs on the planet.
Okay, before we leave transporters, we need to go inside the cell. The chapter highlights vesicular transporters for storage. How is that mechanism different from reuptake?
It uses a whole different power source. See, storage is necessary to protect the neurotransmitters from being chewed up by enzymes inside the neuron. This happens inside synaptic vesicles, and they use a different pump, the proton ATPase. This pump pushes positively charged protons out of the vesicle.
And the neurotransmitter moves in to replace it.
Yes, it's a system called antiport. To keep the electrical charge inside the vesicle neutral, the neurotransmitter, which is usually positively charged itself, moves into the vesicle. It's basically swapping its positive charge for the proton's positive charge. The key target here is VMAT2, the vesicular monoamine transporter 2. It stores serotonin, dopamine, norepinephrine, and histamine.
So VMAT2 is the central storage unit for all the monoamines, a critical hub, and that's why drugs for movement disorders like tetrabenazine act on VMAT2 to control those stores.
It connects a whole cycle. And with that, we can transition to our second major target, the G-protein-linked receptors.
Okay, so if the transporter was defined by those 12 transmembrane regions, what's the structure that defines a G-protein-linked receptor?
This receptor is, well, it's the queen of signal transduction. Its structure is defined by its 7-transmembrane regions.
Yeah.
The chapter visualizes it as a snake winding 7 times across the membrane. When a drug or a neurotransmitter binds to it, it causes a conformational change, a shapeshift, that kicks off this huge cascade of downstream effects.
Like what?
Oh, everything. Altering gene expression, activating or inactivating specific enzymes. A whole symphony of changes inside the cell.
What I found really fascinating here was the idea of constitutive activity. I mean, if there's no neurotransmitter binding to the receptor, shouldn't it just be silent?
Logically, you would think so, but no. Constitutive activity is this low-frequency baseline signal that just happens spontaneously, even in the total absence of an agonist. In parts of the brain where these receptors are packed together really densely, there's always this kind of low-level buzz. And that inherent activity completely changes how we have to think about drug mechanisms.
Okay, let's use the concept from the book to help the audience with this. The agonist spectrum. If transporters were kind of binary on or off, inhibited or not, these G-protein receptors are more like a dimmer switch. A rheostat. Let's start at the top. What's a full agonist?
A full agonist, like a natural neurotransmitter. It turns the light all the way on. It produces the maximum possible signal transduction at that receptor.
And what about a traditional antagonist? We tend to think of it as completely shutting the system down.
And that's the common mistake. A silent or neutral antagonist does not shut the system down. It just blocks the full agonist from binding. Because it has no activity of its own, all it does is return the receptor's activity to that baseline constitutive state. So if the receptor was overstimulated, an antagonist just forces it back to that low-level buzz.
It's like a ceiling. It stops the light from getting any brighter, but it doesn't turn it off.
That's a great way to put it.
That distinction is huge, especially for something like antipsychotic action, where blocking D2 receptors brings hyperactivity back to baseline. But here's the real game changer. The partial agonist. Why does the chapter call this the stabilizer or the Goldilocks solution?
Because it exists right in the middle. A partial agonist delivers a signal that's more than a silent antagonist, but it's significantly less than a full agonist. So if a full agonist is, say, 100% activation, a partial agonist might be hardwired to only ever give you 30 or 40%. This fixed intermediate level of activity is what makes it a perfect stabilizer.
Help us understand that dual action. How can it be both?
Okay, imagine a neuronal system that's deficient in its natural neurotransmitter. The room is dark. If you introduce the partial agonist, it creates activity where there was very little, and it raises the signal to its fixed 40% level. In that situation, it acts as a net agonist.
But what if the system is flooded? The room is blindingly bright with 100% full agonist activity.
Now, when you introduce that same partial agonist, It has to compete for the receptor. It physically displaces the full agonist. And since the partial agonist can only produce 40% activation, the overall signal strength of the system drops from 100 down to 40. In that environment, it functions as a net antagonist.
So it boosts low activity and it blocks high activity.
Exactly. This ability to stabilize unstable neurotransmission is a key insight into why these drugs are so crucial for treating complex mood states that have both highs and lows.
And just to complete the spectrum, we have the functional opposite, the inverse agonist. What does that do to the constitutive activity, that baseline buzz?
The inverse agonist is the active shutdown mechanism. It causes a conformational change that not only blocks full agonists, but it actively inactivates the receptor and eliminates even that baseline constitutive activity. It takes the light below the off state.
That is a very clear spectrum. Okay, let's move to our third and final group of therapeutic targets, enzymes.
Right. So enzymes are the biochemical facilitators. They take one substance, the substrate, and they convert it into another, the product. Most of our therapeutic drugs here are inhibitors. They block that conversion from happening.
The sources describe two different ways an inhibitor can work. Let's start with the more dramatic one, the irreversible inhibitor.
We call these suicide inhibitors. They bind covalently, permanently, to the enzyme. They don't just stop it from working, they essentially destroy it. For that enzyme's activity to come back, the cell has to go through the whole process of synthesizing a brand new enzyme molecule from scratch, which, takes time.
And then you have the reversible inhibitor.
That's where it becomes a competition. The drug and the natural substrate are both competing for the exact same binding site. The inhibition can be overcome, it can be displaced, depending on which molecule is there in a higher concentration or has a better affinity for the enzyme. It's a temporary block.
The chapter mentions a few therapeutic targets, like monoamine oxidase, MAO, and acetylcholinesterase. But the example of glycogen synthase kinase, or GSK3, give us a great insight into neuroprotection.
GSK3 is a really interesting one. It's central to a lot of cell functions, including promoting programmed cell death. The source material notes that the classic antimanic agent, lithium, might get some of its long-term mood-stabilizing effects by inhibiting GSK3. By blocking that pro-cell death pathway, it might actually be promoting neuroprotection and plasticity over time.
Okay, now for what might be the most critical distinction in all of clinical psychopharmacology, something the chapter spends a lot of time on, the CYP450 system. Why do we have to strictly separate CYP450 from the therapeutic targets we've just been talking about?
This is paramount. Transporters, receptors, and MAO, those are all mechanisms of pharmacodynamics. That's how the drug acts on the body to create a therapeutic effect. The huge cytochrome P450 enzyme system, or CYP450, is all about pharmacokinetics. This is how the body acts on the drug. It determines how that drug is metabolized, biotransformed, and eventually excreted, mostly in the liver and the gut.
So it's the mechanism of action versus the mechanism of elimination.
Precisely. And the clinical relevance is just enormous because of genetic variability. The sources show that most people are what we call extensive metabolizers. They clear the drug normally, but because of genetic variants, some patients are poor metabolizers.
Meaning their CYP450 enzymes work very slowly, is that right?
Yes. They don't break the drug down efficiently, which can lead to dangerously high drug levels in the blood, even at a standard dose, and that dramatically increases the risk of side effects. Then on the other extreme, you have ultra-rapid metabolizers who break the drug down so quickly it never has a chance to work. You get treatment failure because the medication never reaches a therapeutic concentration.
Which really underlines why modern clinicians rely more and more on pharmacogenomic testing and drug monitoring. You have to genotype the patient to adjust the dose based on their personal enzyme system.
It connects the genetics of the patient directly to the efficacy and safety of the drug.
That brings us to the close of our deep dive into the molecular hardware. Let's do a quick recap for everyone listening, covering those three crucial targets.
Sure. We established that almost all psychotropic drugs target one of three core molecular structures. First, you have the transporters with their 12 transmembrane regions. We focused on the monoamines, SERT, NET, DATE. Drugs here usually inhibit them to prolong the neurotransmitter signal.
Right.
Second, the G protein receptors with their 7 transmembrane regions. This is all about the agonist spectrum, moving from full agonist all the way down, but with that really critical partial agonist, the stabilizer, right in the middle.
The rheostat.
The rheostat. And third, enzymes. Some are therapeutic targets like MAO or GSK3, but the big story clinically is the pharmacokinetic CYP450 system, which determines how a patient metabolizes a drug.
We've seen how much complexity is built on just these few foundational structures. If we connect this all back to the person taking the medication, what's the most provocative question this knowledge raises for future treatments?
It has to be about that partial agonist. If we now understand that a highly variable condition, like bipolar disorder, has phases of neurotransmitter excess during mania and deficiency during depression, and we know that a partial agonist acts as a net antagonist in states of excess and a net agonist in states of deficiency.
It's the ultimate molecular rheostat, perfectly designed for that kind of problem.
Exactly. So the challenge for you, for future clinicians, is this. How can we better deploy these stabilizing agents to smooth out the extreme peaks and valleys of mood? It suggests they could be vastly superior to simple agents that just offer a one-directional on or off effect. It points to a future where stabilization, not just suppression, is the real goal.
A fascinating challenge to consider as this field evolves. That's a perfect place to wrap up this deep dive into the fundamentals of drug action. Thank you for joining us.